Hello, I'm Brady Torborg, and next to me is Adam Lanners, and we had Humira, otherwise known as adalimumab, for our drug presentation. Humira is a DMARD, it is an anti-humatics, it is TNF alpha inhibitor, and it is a biological class.
For some of the dosages, it depends on what the patient's situation is going on. So the range can go from 40 to 160 mg every other week. Some of the dosages for plaque cirrhosis would be 80 mg. They have rheumatoid arthritis, 40 mg. Psoriatic arthritis, 40 mg with a loading dose of 160. And Crohn's would have a loading of 160 and 80 biweekly.
Some of the indications: Humira is a drug that reduces the signs and symptoms of moderate to severe rheumatoid arthritis, such as joint swelling, pain, and fatigue. It is also approved for the treatment of psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, Crohn's disease, uveitis, and hidradenitis suppurativa.
Administration of this drug usually is a single-use pen, which you can see a diagram in the bottom right side. The drug is often administered under the skin through a syringe or pen like you can see. The drug is usually administered after the initial loading dose every other week to maintain the functioning level of the drug in that patient's system.
Some precautions and contradictions: must have a negative tuberculosis test before using this medication, negative for hepatitis B and C, heart disease past or present, fungal infection present, and no other live vaccines while taking this medication. Humira can temporarily lower the number of white blood cells in your blood, which may increase the chance of getting an infection. It can also lower the number of platelets, which are necessary for proper blood clotting.
Some ADRs: pain, swelling, infection, warmth, itchy, and redness, which you can see on that right side again. Cancer, body aches, lightheadedness, cough, stomach fullness, gas with stomach pain, or some trouble sleeping.
The mechanism of action: Humira binds specifically to TNF alpha and blocks its interaction with the P55 and P75 cell surface TNF receptors. It also lyses the surface of the TNF expressing cells in vitro in the presence of the complement, and it does not bind or inactivate the TNF beta. TNF is a naturally occurring cytokine that is involved in normal inflammatory and immune responses.
Some pharmacokinetics for it. Average bioavailability following a single 40 mg subcutaneous dose was 64%. The mean terminal half-life was approximately 2 weeks, ranging from 10 days to 20 days across the studies we found. Minor increases in apparent clearance was also predicted in RA patients receiving doses lower than that 40 mg recommended dose, and in RA patients with a high rheumatoid factor or CRP concentrations. These increases are not likely to be clinically important, though. No gender-related pharmacokinetic differences were observed after correction for a patient's body weight. Healthy volunteers and patients with rheumatoid arthritis displayed similar adalimumab pharmacokinetics.
Does the drug require monitoring? Must continue regular visits with your rheumatologist. Your doctor will monitor you for any improvements or signs of infections. Changes can be based on new diagnoses.
Some special considerations. Tell your doctor if you are pregnant or you become pregnant while taking Humira. It's recommended that you don't become pregnant while taking the drug. You should not breastfeed also while taking Humira. And then if you've had heart failure, hepatitis B, cancer, liver damage, or an allergy to latex, your doctor may want to look at some other treatments before trying Humira.
Some PT implications of Humira: pain management for RA systems, assisting in the progressing of the patients, and this may mask the underlying effects of the pathology that may contribute to your diagnosis and prognosis of this patient.
Some studies that we found with Humira. So in the first one, in RA patients where methotrexate was deemed inappropriate, tocilizumab monotherapy was superior to adalimumab monotherapy. And then the next one we found in patients with RA where DMARD's treatment had failed already, adalimumab monotherapy achieved significant, rapid, and sustained improvements in disease activity, also improved the patient's physical function. And the last one we found in our patients were Sarilumab monotherapy demonstrated superiority to adalimumab monotherapy by improving signs and symptoms. So we found that the drug does work, but there might be other drugs to try before it if it doesn't work the best. So it still works, but maybe other drugs that work better.
And here are our references. Thank you for listening in on our information about Humira.